After having discussion with them, the Kafaja and Pittaja Pramehas, we will go into the Vasaja Prameha. Among the Vasaja Prameha, the first is the Sarpi Prakasham, Sarpi Mehi Mehadi, Sarpi Meha. Sarpi Meha, where the urine will be like the ghee. Now there is Fena Meha in the Kafaja and Sarpe Meha, there is a similarity because in both the conditions there is a Sapena and Acha. The difference can be about the density. So when there is a very high dense lipiduria, it could be considered as the Vataja Prameha, Sarpe Meha, and when it's a moderate, it could be like the Fena Meha, which is a Kafaja Meha. Now, lipiduria or presence of the lipids in the urine can be produced due to multiple conditions, varieties of the conditions. And in general, whenever we see the lipiduria in the clinical conditions, usually the probable diagnosis is based upon the age. It could be starting from congenital nephrosis in a newborn to the minimal changes focal glomerulosclerosis or diabetic nephropathy there somewhere in the younger age or middle age. Nephropathy which is involving the membranes of the kidney around in the middle age, later half of the middle age like 50s, and in the older age it's the amyloidosis which is quite common. And most of these conditions again would have a gradually progressive advancing nature. In later ages, paraneoplastic conditions also, like a patient having a malignancy in any of the system may present with a lipiduria as a complication. So the whole the purpose of discussion is lipiduria as such, presence of the lipids in the urine could be produced due to a large number of conditions, and the usual priority of the diagnosis will be based upon the age. But doesn't this age line doesn't confirm that, but it also has to be considered as one of the possibilities. And usually the later half of the life, the prognosis is extremely poor, and it usually ends in a end stage renal failure. So probably this later half of that lipiduria could be considered as the sarpimeha, whereas the first half, where the prognosis is somewhat better and the causes are seen in relatively younger age, could be considered as a phenomena. That could be one of the possible explanation of this lipiduria. The next is Vasa Prakasham Musamehi, very high specific gravity of the urine. Could be the Vasa. Vasa is again a relatively thick consistency, having that thicker consistency than the other lipids, fat acids. Causes of high specific gravity could be many. Again, here also it may not be a single condition. Starting from the diabetes mellitus, where the sugar itself would be adding to the this specific gravity. It could be even like due to a hormonal abnormality like ADH secretion being this abnormal, which is also combined in named as a syndrome of inappropriate ADH secretion. Or it could be like the other diseases like Addison's disease, heart failure, hyper. Even patients who have a severe dehydration can result in a high specific gravity of the urine. So, are any of the conditions where there is a renal artery stenosis, or even a patient who was on shock and for quite a long time he is not resuscitated, it also can result in a high specific gravity. So, Vasameha, which is the real Vasameha, probably it could be that the syndrome of antidiuretic hormone secretion inappropriate and could be, or any of these conditions could be considered as the Vasameha. In the conditions like hypernatremia and the dehydration, management is relatively easier and the prognosis is better. Whereas the conditions like Addison's disease, heart failure, or even the inappropriate ADH secretion conditions, the management will be difficult and prognosis also will be variable. So we have to consider all these issues as the Osameha. Then comes the Kshaudra Meha is the real chronic renal disease, which is end stage or Madhumeha, the real Madhumeha or Kshaudra Meha, the other name. And the end stage renal failure, chronic renal disease, is the important issue. What happens is in all the conditions, in all the disease conditions, of nephrology, the last stage would be the end stage renal failure, where the kidney would not be able to functioning. Like now, irrespective of the cause of the disease, the renal functions will be gradually impaired, and this is generally considered as the assessment of the chronic stage disease conditions, and depending upon the GFR and the, the renal damage, amount of the renal damage. And usually we follow this graph. This graph is a very standard chart graph, where in the normal conditions the GFR is at around maybe 11 to 15 too, and there is within the normal range. Now, a minimum reduction of kidney tissues. Now, this is a very important issue. A impairment of the kidney functions to a moderate degree might not show any clinical conditions and clinical symptoms. Everything may be not, seeming to be normal, but there is a significant kidney function impairment. Whereas a moderate reduction of the kidney functions may show slight variation in the glomerular filtrate rate, and there could be a significant damage in the kidney tissue. So this graph would give you an idea and also predict about the risk. So a patient presenting with a renal disease, to predict whether the risk about how the whether the patient would go into the end stage renal failure or not, you generally follow this graph, where the glomerular filtration rate is considered as one of the important categories. Anyway, that's about the Kshaudra or Madhumeha as such. So from my point of view, I would consider Madhumeha as end stage renal failure, not the diabetes mellitus, though popularly it is named as diabetes mellitus. Okay, we'll stop at that part. We will not make it big controversy. Then next is the Hastimeha. Hastimehi matta matangavat anuprabandham Hastimehi mehati, where the evacuation is somewhat incomplete and a slow repeated urge for micturition and relatively low pressure micturition outcome. It is a common condition, a urge for micturition being more frequent. Now, urge for micturition being more frequent is usually due to overactive bladder. Now, in general, that overactive bladder is considered as a urological condition, not the nephrological condition. So, a normal bladder would produce an urge for micturition when the quantity in the bladder reaches around 400 to 500 ml. And till then, the bladder, the detrusor muscle, as well as the total, all the muscles of the bladder, trigonic muscle also, tend to be relaxed. They tend to relax as the urine is added, so that the intravesical pressure doesn't reach or doesn't cross 14 millimeters of mercury. But once the quantity has reached, in a normal condition, once the quantity has reached up to 400 ml, the bladder muscles would not relax further. So any addition of a volume would be increasing the pressure, which gives you urgiform micturition. And that urgiform micturition can be sustained till the pressure goes up to 40 centimeters of water. So 40 centimeters of water is the maximum average pressure which is tolerated by the bladder. But once it goes beyond that pressure, you may not be able to control the urge. You have to go for micturition, and urgency for the micturition sets in, and then the whole process of the micturition starts. The whole process of the micturition starts with the relaxation of the trigone, contraction of the trigone of the bladder, and when the contraction occurs in the trigone area, the neck of the bladder becomes somewhat funnel-like, and hence the flow starts into the urethra. At the same time, the bladder muscles also contract along with the contraction of the abdominal muscles, which push the urine out, and it results in expulsion of the urine. So that's the normal process. In case of some overactive bladder, there could be two issues. One, the bladder may not be able to relax, and as to addition of the fluid, water is this urine is added, the immediately the pressure may raise, and that results in the whole cycle of micturition. Or it could be like the bladder may be overactive and it tends to contract. It tends to contract as such. Conditions like urinary tract infections, they tend to produce that irritation. Whereas the same urgency for micturition, where the bladder capacity could be reduced, could occur in case of any mass in the abdomen, like enlarged uterus or ovarian cyst, or any other mass in the abdomen, I would say, intra-abdominal pressure being increased, giving lesser scope for the bladder to relax. It also can result in a increased frequency of micturition. Or increased frequency of micturition also can occur where the bladder, it's not really overactive bladder, but the whole mechanism of neural control of the bladder, the relaxation and the contraction of the muscle may go up. Or in case of neurological disorders, which where we have autonomic bladder, automatic bladder, and so on, or even in case of the diabetes mellitus. So, Hasti whether it has to be a nephrological condition or whether it is a urological condition, again there could be a bit controversy. I would consider this way, like the nephrological conditions like diabetes mellitus or the neurological conditions which may affect the bladder functions, may result in urinary tract these increased overactive bladder or hyperactive bladder syndrome conditions can be considered as a Hasti. So that's about the Vatale prameha. Now, because Sushruta has mentioned about that different colors of the urine and the colors of the urine being used as a criteria to make the diagnosis, and from the clinical point of view, is one of the important clinical part as such. And here again, the density of the color and the type of the color also can be seen, considered as a criteria, and this is where you get all these variations of the colors. Pale yellow color is the normal, healthy and hydrated. More the hydration, the density of the color becomes lesser. Dilute urine would have relatively whitish color. Gradually, as this concentration of urine increases, it becomes somewhat yellow. A bright yellow is usually due to excess of vitamin B12, or occasionally a same bright yellow could also be a sign of jaundice. Red is in due to the blood in the urine. Again, depending upon the density of these colors, you can predict like which is the quantity of the blood also. In case of the orange color, it's usually dehydration, produced with dehydration, or even certain drugs also can produce a orange color, or the food also can add to the orange color. And purple is a porphyria. Porphyria we have already discussed in case of the Manjistameha, and that's the usual color changes again. Brown color again usually is with due to certain drugs, very common with the certain drugs like phenytoin and so on. Phenytoin, anti-epileptic drug, it's well known to produce that brown color urine. And of course, yeah, there is um, yeah. Yeah, phenytoin is a major, very common condition, drug which produces that. Green color, it's again due to certain drugs and dyes in the food also can produce a green color. Jaundice, of course, produces a yellow color, and yellow is again not that bright yellow, it would be somewhat darker type of the yellow in case of the jaundice. That's how the color can be a criteria to make the diagnosis. Now, Sushruta has given you some more signs by which you can identify the variety of the prameha based upon the clinical signs. Makshikopasarpanam, Alasyam, Mamsopachaya, Pratishaya, Shaithilya, Arochaka Avipaka, Kafa Praseka, Chatti Nidra Kasa Shwasasteti, Shleshmajanam Upadravaha. A Shleshmaja prameha usually ends up or can lead to the other clinical signs like where the urine is attracted by the insects. Now, important, the urine is attracted by the insects only, not only in case of diabetes mellitus, it could be the proteinuria also, there could be major this same feature which could be observed. And that insects being are being attracted by the urine is a area which we need to explore. The contemporary science doesn't really mention this, but it's a fact which can be observed, and hence it's one of the area which needs some evaluation further in the present criteria. Then Mamsopachaya, where the person would have obesity, Pratishaya, repeated episodes of nasal discharges, and a general debility, and indigestion, abnormalities of the digestion process, salivation, vomiting, and excess of sleep, dyspnea and exertion, also can be the complications of the Kapaja prameha. Whereas in the Pittaja prameha, Vrishnayoho avadaranam, Bastibihdaha, Medhatodaha, Hridishu Amlika, Jwara Atisara Arochakaha, Vamatuhu, Paridhupanam, Daho, Murcha, Pipasa, Nidranashaha, Pandurogaha, Pita Vinmutnetratum Chili, Paitigana. In the Paitika variety, Pittaja variety, it could be disruption of the genital area, scrotal as well as subscrotal tissues, abnormalities of the bladder functions, and pain in the genital area, and hridishulam, pain in the chest also, having sore erections, burning sensation throughout the body, vomiting, or yellowish discoloration of the urine can be a sign of, or can be the complications of the pittaja prameha, or these also can be considered as a sign as such. Then Hridraha, Laulyam, Anidra, Stambha, Kampaha, Shulam, Bhaddhapurishatam Jeti Vatayanam. In a Vataya Prameha, there would be a palpitation and the abnormal behavior. Laulyam is a abnormal behavior where the person may have psychological symptoms or loss of sleep, Stambha, this debility, particularly rigidity of the body, and tenderness, and these tremors also can also be, and constipation. This could be the upadrava of the pramehas. Evamete vimshati pramehaः sopadravaः vyakhyataः. That's about the 20 pramehas. The next comes in the prameha pilaka. वसमेदभ्यां भिन्न अभिपन्न शरीरस्य त्रिभिर्दोषैः अनुगतधातोः प्रमेहिणः दश पिडकाः जायन्ते. Pidakaha are local ulcers, are local eruptions which result in ulcers, as are another of the complications of all the pramehas. And very commonly, the madhumeha, the end stage renal failure, or it could be any of the pramehas. It's not that it's only the end stage renal failure. Popularly, in the present day situation, we consider the diabetic ulcers, diabetes mellitus and diabetic ulcers, as the very commonly seen frequent septic complications of the renal pathology. But septic complications can occur in any of the renal pathology, any of the nephrological conditions. Now, diabetes mellitus now is categorized as a metabolic disease, not the nephrological condition. But from Sushra's point of view, that too is a nephrological condition, or prameha, in the Kapalia variety. Now, that's all the issue of maybe a perception, not a very important issue, a very significant issue. It makes a huge controversy. It's not the issue of controversy, it's the way you look at it. Both of them are true. Diabetes mellitus also has a nephrological involvement as well as a metabolic involvement. Now, from the present day's point of view, because the whole therapy is based upon the metabolic line, we consider this as a metabolic disorder. So, instead of going into controversy, look at it in an integral manner. And as far as the diabetic ulcers are concerned, because it is the very popular one, diabetic ulcers are concerned, we usually categorize them under the stages in the present day situation. Stage is 0 where there are no ulcers, and in the diabetic conditions, because there is a pressure, sensations are impaired. The first stage where there will be just a superficial ulcer. Stage 2 is where there is a deeper ulcer, and which involves the adipose tissue layer, and they tend to become chronic. And stage 3 is when it has become much deeper and involves the even up to the level of the bone. Stage 4 is a stage of osteomyelitis, and the stage 5 is gangrene. Or usually the other way, another way of classifying this diabetic ulcer is the stage of cellulitis, stage of extending cellulitis, stage of osteomyelitis, and stage of gangrene. So either it could be the 4 stages of stage of cellulitis, extending cellulitis, and the osteomyelitis, and the gangrene. So characteristically, there is a impairment of the blood flow gradually, and impairment of the immunological reactions. The localization reactions tend to be weaker or failure in case of the diabetic ulcer. And the similar principle is true in all other renal pathologies. Diabetic ulcers are the more common variety. Anyway, because the diabetic ulcers are more common, some feel that they are the signs of madhumeha. Not necessarily. In Sushruta, it's mentioned like any prameha can result in the prameha pidaka. That's a bit about the controversy. We will not go beyond that. And these are named as Sharavika, Sarshapika, Kachapika, Jalini, Vinata, Putrini, Masurika, Alaji, Vidarika, Vidrika, Cheti. Now, uh, the Sharavika is Sharav Matra Tadrupa Nimra Madhya Sharavika. Sharavika is something like the plate. Sharava is the plate which is used, or pan used for your dosa preparation. And it has a similar shape where a flat ulcer, wide surface, flat ulcer with maybe a inverted edge and suggestive of avascularity, so relatively superficial, is the Sharavika. Then the Gaurasakshma Samsana Pramana Sarshapi. Sarshapi, the resemblance is that of the Sarshapa, the seeds of sesame, where multiple small pustules are formed, and usually it's also a variety of the carbuncle. A carbuncle, diabetic carbuncle, can present with these kinds of pustules when it is usually produced due to gram-positive organism. Gram-positive organism induced carbuncles are presented with these multiple pustules and induration, whereas gram-negative organism induced carbuncles are usually darker in color and quite deep as such. So this is one of that variety which is practically seen. Sadaha Kurma Samsana Jaya Kachapika Budhihi. Kachapika is it's a hard indurated mass which is felt and felt like tortoise. Now this also is a stage of carbuncle, and usually when the carbuncle is presented with gram-negative organism and more of vascular pathology, you will see that kind of an appearance where the induration is more and the surface is harder, rough as such. Now, purpose of showing these images is to show that the exact description can be seen in the patients. Then, Jalini, Tibradaha, Mamsajala Samavata. Jalini, where you will see some network-like substances or the slough seen in the wound, where the tendons and ligaments could be seen, suggestive of a more depth of the ulcers. Now, Mahati Pidaka Nila Pidaka Vinata Smita. When there is a single pustule and which is somewhat deep, it's called as a Pidaka. It's again a septic focus which is presented as an abscess. We usually consider this as an abscess, superficial abscess. That's the Nila Pidaka or Vinata. That's the other way. Then Mahati Alpachitagnya Pidaka Sarputrini. When there are more than one ulcers, and ulcers are tending to expand along the sheaths or spaces of the tissue spaces, where one ulcer results in the other and there is an interconnection. That's called as a putrini. So it's a mahati alpachita. Initially a big ulcer and then it tends to extend, producing more and more of the ulcers is the typical presentation of a putrini as such. And Masura Samasansana Jayasa Masurika, where vesicles are produced and vesicles which resemble that of the Masura Dhanya, relatively bigger. That's Masurika. Now, this also is a sign of diabetic ulcers. You may present with this kind of presentation of diabetic ulcers, particularly in a avascular area where the blood flow is markedly reduced and diabetic ulcers are set in. Usually, they start with vesicles. Then Rakta Sita Spotavati Darunitva Allergy Mata. When there is a severe infective pathology in this ischemic area, it can present with either reddish or blackish vesicles, again, blebs as such, not the vesicles, blebs. And the contents would be heterogeneous, reddish or blackish content. That's considered as allergy. And such a condition is also having a poor prognosis and having severe pain, also Daruna allergy. Then Vidari Kandapratutta Kathinacha Vidarika. When there is a very deep-seated this carbuncle, which may involve even up to the level of the muscles. It's also quite common. Rather, this is a very common presentation of the diabetic carbuncle, usually presented at the pressure points of the body, like back, or those areas where the fat tissue is thicker, like back and abdomen. That's the Vidarika, a deep-seated carbuncle as such. Then Vidrave Lakshana Yukta Jnayat Vidradika Buddhi. When typical Vidradi, the abscess-like conditions where the pus is formed and the pus is accumulated, which shows that the typical tenderness and difference in the consistency, some the central area being soft and the periphery being relatively firmer, suggestive of the fluid formation. That's the Vidradika as such. It looks like anything, conditions like any other infective pathology. The only thing is the diabetes mellitus, which enhances the possibility of the spread. The localization becomes relatively weaker in case of an abscess, whereas a well localized condition in other conditions we simply name as an abscess. But in a diabetic condition, a abscess looking similar to the other conditions has to be carefully evaluated for the signs of extension, that cellulitis, extending cellulitis along with some partial localization is the issue. Now more about that cellulitis and the abscess formation we will discuss when we discuss about the vidrati. ये यन्मयः स्मृतामेः तेषां मेधास्तुतकृताः. Now the dosha assessment in a prameha is quite important, and all the complications of the pidakas, the presentation of the pidaka, involvement of the doshas would be based upon the dosha involving that particular prameha. Like a kapha prameha, like the Shaudra, this Shankara Meha, that's the diabetes mellitus, produces mainly more of Kaphaja variety. If it is the Pittaja Meha, it produces Pittaja variety of the ulcers and so on. So Krishnam Shariram Nishpitya, Medo Madhya Vasayitaha, Azat Prakramite Vayu, Tena Asadhyastu Vatajaha, because the whole disease, the tissues throughout the body and the mesas and meja throughout, it involves and it tends to move downwards. The Vataja Prameha are considered as asadhya. Complications of Vataja Prameha are considered as asadhya. In another context, Srishti refers to this issue also, because the doshas are moving downwards and the distal most point of the body is the legs. Incidents of the prameha pedaka are more common in the lower limbs than in the other part of the body. So this also is true. Then another important rule is prameha purva rupanam akritir yatra drishyate kinchityapi adhikam mutram tam pramehinam adishet. Now this is a point which I just referred to in the beginning of the classes, like about the level in which we make the diagnosis. So according to our Ayurvedic principle, the Prabhuta, Avila, Mutraka are the clinical criteria to make the diagnosis. Sushruta says you need not wait up to that Prabhuta, Avila, Mutra. Even if you have some one suspecting symptom, Prameha Purva Rupanam Akriti, even that suspicion of one of the Prameha Purva, and with at least slight increase in the quantity of the urine, kinchit chapi adhikam mutra. If there is a slight increase in the urine, you have to make the diagnosis of prameha, suspect the prameha. So prameha, that you need not wait up to the level of the prabhuta mutra. So a preemptive diagnosis, a early diagnosis is possible if you are bothered about any of the prameha pura rupa and a slight increase in the quantity of the urine. कृष्णानि अर्धानि वा यस्मिन् पूर्वरूपाणि मानवे प्रवृत्तमूत्रम् अत्यक्तं तं प्रमेहिनम् आदिशेत. It could be like if there is any of the half of the Purva Lakshanas which are mentioned, or maybe all the Purva Lakshanas are mentioned, even if there is not much of a significant urinary signs like increased quantity, you need to consider it as a pramehanam. Prameha has to be suspected. Pidaka pidram gadham upasthastam upadravaihi madhumehinam ajaste sta asadhyah prakirtitah. Once there is a pidaka, even then it can be considered as a madhumeha. Madhumeha is usually vata prameha and the end stage. It will come to that end stage, like any of the pramehas may end up in madhumeha. But once there is a pidaka and there are other complications, such conditions also can be named as a madhumeha. So from that point of view, diabetes mellitus will presenting with the complications like the diabetic gangrene or maybe the ulcers can be considered as a madhumeha. Now, the another very important classical clinical signs of the prameha, renal pathologies are the gradual clinical evolution of the clinical symptoms. Suchapi gamanat sthanam, sthanat asanam ichhati, asanat runte shayam, shayanat swapnam ichhati. A person who is moving about feels like or prefers to sit, or a person who is sitting prefers to lie down, a person who is moving, he prefers to stand. A person who is standing prefers to sit down. And a person who is sitting tends to sleep. And a person who is sleeping will go further deeper in sleep. That means these are all the degrees of lethargy. Now, lethargy or reduced exercise tolerance is one of the most important common clinical symptoms of a renal pathology. A failure of the renal functions or impairment of renal functions is seen clinically, and the most common and earliest clinical symptom in case of impairment of the renal function would be reduced exercise tolerance. And that description of this, like a person who is walking prefers to stand and standing person preferring to sit, is the most beautiful description of that lethargy as such. यथा हि वर्णानां पञ्चानाम् उत्कर्ष अपकर्षकृतेन संयोगविशेषेण शबल बभ्रु कपिल कपोत मेचकादीनां वर्णानाम् अनेकेषाम् उत्पत्तिर्भवति एवमेव दोष धातु मल आहार विशेषेण उत्कर्ष अपकर्षकृतेन संयोगविशेषेण प्रमेहानां नानाकरणं भवति. Now, in the text there are 20 varieties of the prameha mentioned, but you need not limit to only to the 20. It could be innumerable due to the variation of the possible components of the pathology. Possible components of the pathology could vary, and hence the number of pramehas also can be innumerable. So from the present day's point of view, when you go by the biochemical parameters, you will have hundreds and hundreds of such conditions which can result in impairment of the renal functions, and hence all of them also can be considered where the prameha can be produced. And Sushil gives a simile to that. The simile is as there are 5 basic colors. Now, according to Indian culture, there are 5 basic colors. Western, there are 3 basic colors. Anyway, the 5 basic colors like the red, green, yellow, which is the common basic colors according to Western, and Indian, black and white also are the basic colors. Now, by combination of these basic colors, you can have innumerable number of variations of the colors. Similarly, the impairment of the components of the pathology of prameha can produce innumerable pramehas. And the last part is sarvayeva pramehastu kalena apratikurvatah madhumehatvam ayanti tada asadhyaha bhavanti. All the pramehas, if they are not treated properly, they may end up in a madhumeha where the renal failure occurs. Now, it's a very important principle, and the same which we have already discussed, but one of the important reminder is in case of the nephrological conditions, by the time you see a biochemical changes where the blood test shows abnormality, the amount of the kidney damage could be quite huge, like around 80 to 90% of the kidney is damaged. Till then, you may not see any of the clinical your biochemical parameters like renal functions being impaired, creatinine level, urea level being altered, shows that there is a significant damage, and hence the early diagnosis is usually based upon glomerular filtration rate, and glomerular filtration rate also would be variable. In the stages, initial stages, it could be higher than the normal, and later on there is a gradual reduction. So that makes the diagnosis of nephrological conditions difficult, and that difficulty in the diagnosis itself would add to the poor prognosis in the nephrological conditions. And hence, nephrological conditions are generally categorized as a condition where there has to be a very active and early diagnosis needed, and intervention is needed. With this, we will conclude this chapter. इति सुश्रुतसंहितां निदानस्थाने प्रमेह निदानं नाम षष्ठोऽध्यायः. If there are any questions, I will try to answer, and then we will conclude today a bit early. Like there is one question, doubt about previous topic, how to differentiate between palmar eczema and allergic dermatitis, psoriasis. Now, the eczema would be usually presented with the linear cracks because of the involvement of the dermis. So, when there are line-like cracks, linear cracks that's a sign of an eczema. Psoriasis is where there is a scaling. You will have thick scales, and the characteristic waxy scale is a sign of psoriasis. The term allergic dermatitis is a broader term where involvement of the skin due to allergy is called as allergic dermatitis, and it can present with any of the lesions. It can result in an eczema, allergic eczema can occur, or it could be very superficial like erythema, or so on. So allergic dermatitis, there is no such characteristic feature. When you know that the history is of, or the source of the lesion, the origin of the lesion is due to allergy, you call it as allergic dermatitis. So that's a very vague term. Then the next, another question is, If at all considering Madhumeha as an end stage renal failure, will there be elevated level of PSA? No, PSA is very specific about the prostatic pathology, and it's not necessarily a sign of end stage renal failure. Conditions which have resulted in increased PSA may result in renal involvement. That's a later effect. It's not that way. So I think that's the way we have to look at it. Then there is another question like management of plantar eczema and dermatitis psoriasis. Of course, management part we will discuss when we go into Chikitsa, but because the question is asked from our point of view, when we manage any of the conditions, the important will be the dosha lakshanas. If you have more of vata lakshana, you will prefer vatagna ushadis like Kaishora Gugulu or so on. That's what I usually prescribe. If there is a pitta lakshana, I would prefer kamaduga like drugs. If there is a kapha lakshana, I would be preferring the kapagna ushadis like maybe gandhaka rasayana or so on. So it's about the clinic Lagusud Shekhar in Kapaja variety. So ultimately, irrespective of whether it's eczema or psoriasis, our drug selection would be based upon the doshas. Then these diagnoses would be important to predict the prognosis and the duration of the treatment. So that part, and of course, more discussion about that we will discuss when we go into the chikitsa part, right? So, one patient is having GFR is 10 and he is not willing for dialysis. Can we? It's quite difficult. A person who has such a low GFR is very critical, and the only life-saving treatment could be either dialysis or renal transplant. So, as far as I know, it's difficult to manage with any of the drugs, not only IBR, not any medical management. Non-dialysis or therapy other than supporting the kidney functions like dialysis or transplantation, management will be quite difficult. So, as far as I know, I don't have any experience of treating such a low GFR patient like where it's 10. Right. So, any more questions? Right there. Because as there are no questions, we will wind up a bit early today. We will continue the next chapter in the next class. So, right.
Thank you, sir.
Thank you.